So, why are we talking about brains in kids with congenital heart disease? The story of congenital heart surgery in Alberta started in the mid 1950s with this man, John Callahan, pictured here. He was one of the great pioneers in cardiac surgery worldwide. He joined the Department of Surgery at the University of Alberta in 1955. He performed Canada's first successful open heart surgery the following fall in 1956 on a patient with an atrial septal defect or a hole in the top chambers of the heart. This was followed shortly by the first successful blue baby operation in an 18-month-old infant, and later with a 4-year-old girl with tetralogy of Fallot in 1957. Ironically, his great-granddaughter would need her own repair of tetralogy of Fallot 50 years later, with her surgery lasting only 2 hours compared with Dr. Callahan's first 10-hour tetralogy repair. Cardiopulmonary bypass, or the heart-lung machine, did not exist in those early days of heart surgery. Instead, surgeons used cross-circulation for open heart surgery. A child was connected to their parent's heart, with the child here on the right and the parent here on the left, which oxygenated the patient's blood and pumped it back in. This technique was used only for a short period of time as it put the lives of 2 people at risk instead of 1, and ultimately it was abandoned. It was replaced by a pump oxygenator, the earliest version of the heart-lung machine, which Callahan used for his first ASD surgical closure. Along the way, he was joined by a fellow named John Hopps, an electrical engineer from Ottawa's National Research Council. He designed an electronic device that would become the first pacemaker, which he tested in a dog in 1950. He later needed a pacemaker of his own at 65 years of age. Surgery for congenital heart disease was in its infancy in those years between the 1950s and 1980s. Prior to the 1980s, it was uncommon for children with complex congenital heart disease to survive even into adulthood. Um, this is data from Norway showing their survival rates between 1971 and 2011, and these rates were fairly similar in centers worldwide. In this image, lines in purple and red show survival rates in the 1970s and 1980s, while green lines show survival in the early 2000s. Along the vertical axis is survival in percentages from 100% survival at the top and 0% survival at the bottom. And along the horizontal axis is years from birth. Most notably are dramatic improvements in survival in single ventricles like hypoplastic right and hypoplastic left heart syndrome, truncus arteriosus, interrupted aortic arch, and pulmonary atresia. There were 4 key technological breakthroughs that changed the landscape of caring for children with congenital heart disease. Cardiopulmonary bypass, or the heart-lung machine, allows the blood to be redirected away from the heart to a machine that filters, heats, and oxygenates the blood before returning it back to the systemic circulation. This allows the surgeon a bloodless field. It's run by a perfusionist with his machine here and sitting back here in the background. The development of the IV medication prostaglandin to keep the ductus arteriosus, or what we call the duct, open to allow enough flow to the lungs in a blue baby like this one was game-changing, as was the ability to perform cardiac surgery in neonates, which are babies in the first month of life. Finally, the development of cardiac catheterization allowed early diagnosis of congenital heart disease long before we had cardiac ultrasound, called echo. We still use catheterization for both diagnosis of heart problems, but also to treat some heart diseases. These are pictures of some of the devices that we use down here that are situated on the ends of the catheters. We use balloons to stretch blood vessels to allow blood to go where we need it to go. We can use devices to close holes in the heart or blood vessels to stop blood from where we don't need it to go. We can mount these metal tubes called stents on the outside of balloons and position them across blood vessels that we are trying to open to keep the blood vessels held open. We can also implant valves inside these stents so that we can deliver valves by cardiac catheterization rather than by surgery. This graph on the left shows the impact of these developments on survival of patients with congenital heart disease in the UK. Over this 50-year period, you can see the decline in deaths of babies under 1 year of age, shown in blue, with our improvements in treating severe heart disease, and the shift to more deaths of older children in yellow possibly from long-term complications of their heart disease. On the right is another graph looking at long-term survival in almost 36,000 CHD patients in a large US registry. It shows very good to excellent long-term survival with 95% of children with mild diseases like ASDs and VSDs surviving to at least 25 years of age, compared to 89% with moderate disease like AVSD, transposition of the great arteries, and tetralogy of Fallot, 72% with severe two-ventricle disease like complex left heart obstruction or complex pulmonary atresia, and more than 44% of those with single ventricle disease like hypoplastic left heart syndrome. With such remarkable achievement in survival for these children, we've seen a shift so that the number of adults living with congenital heart disease in the US and Canada far exceed the number of children living with congenital heart disease. We're just starting to appreciate the neurodevelopmental challenges these adults with CHD have had. And then we're witnessing the problems that our kids with CHD are struggling with. Children with CHD have been shown over and over to have a specific pattern of neurodevelopmental challenges. We will learn more about these issues in the next sessions of these series. But in brief, about one half of children with complex heart disease have neurodevelopmental disability, most mild, but still very impactful on their lives. We know that our kids generally have normal IQs, but often in the lower range. Many struggle with speech and language. They're frequently impulsive and hyperactive. There are higher rates of autism and inability to make or keep relationships. Many have anxiety or depression later in life. These challenges impact the quality of life for many adults with congenital heart disease. This is data from a Dutch registry showing that both men and women with severe CHD may fail to finish secondary school. Many struggle with employment and low income. A large number of men with severe CHD may remain single throughout their lives. Many adult patients suffer from poor self-esteem, and there are high rates of anxiety and depression. So, let's look at some of the etiologies or possible causes of changes to the brain in children with CHD. By 9 weeks or 2 months of age in gestation, seen up here, the brain is a small, smooth structure, but the basics of the nervous system are already established. Over the next months, the brain structures grow and the outer parts of the brain begin to fold into distinct brain regions. Neurons in these special regions begin to make chemicals that will allow them to connect to other nerve cells. The fiber pathways that become the brain's information superhighway within white matter start to form. The third trimester, between 6 months and 9 months gestation, is where much of the growth and folding of the brain occurs. Even after birth, there is ongoing brain development. By 6 years of age, the brain has reached 90% of its adult volume, and by age 25, it's fully developed. Many types of congenital heart disease produce abnormalities in blood flow in the fetus. First, a reminder of how blood flows normally through a heart. Remember that the right side of the heart handles deoxygenated blood returning from the body and sending that through the lung arteries or pulmonary arteries to the lungs. When we breathe in, oxygen floods the blood, and that pink blood returns to the left side of the heart through the atrium into the ventricle and through the aorta to deliver that pink oxygenated blood to the brain and to the abdominal organs. As a fetus, babies are not breathing, and instead, pink blood is returning to the heart from the placenta, bringing the pink blood that streams across the hole in the top chambers of the heart called the foramen ovale to deliver it to the left side of the heart and through the aorta to the developing brain. Blue blood returning from the body, both above and below the heart, actually streams into the right ventricle and through the ductus arteriosus to the abdominal organs. Thus, preferentially better oxygenated blood goes to the developing brain and less oxygenated blood to the developing abdominal organs. On the right is a cartoon of transposition of the great arteries, and in this scenario, the two great vessels are swapped so that the aorta comes off the right side of the heart and the pulmonary arteries arise from the left side of the heart. Pink blood from the placenta still streams through the foramen ovale to the left side of the heart, but instead goes through the ductus arteriosus to the abdominal organs. Blue blood returning from the upper and lower body still go into the right ventricle, but instead are directed to the developing brain. Thus, in transposition of the great arteries, the developing brain of fetuses get blood that has too little oxygen and nutrients at a time when it is most vulnerable. This is a cartoon of hypoplastic left heart syndrome where the left side of the heart is underdeveloped. Often the mitral valve and the aortic valve are very small or may not open at all, restricting the amount of flow getting into the aorta. In this case, pink blood returning from the placenta cannot pass through the foramen ovale into the small left heart and instead goes into the right ventricle along with blue blood returning from the upper and lower body. This mixed blood passes through the ductus arteriosus, with flow going to the abdominal organs, but flow also has to pass backwards into the aorta to deliver that flow to the developing brain. In hypoplastic left heart syndrome, the aorta is often very small or hypoplastic and may also limit the amount of flow that passes through the aortic arch. Thus, in hypoplastic left heart syndrome, fetuses get too little flow that is low in oxygen and nutrients when their brains are most vulnerable. We're learning more and more about the genetics of heart disease. We see congenital heart disease in many genetic syndromes, including trisomies like Down syndrome, trisomy 13 and 18, as well as microdeletion syndromes like DeGeorge and Williams syndrome, and single gene disorders like Noonan and Kabuki syndrome. We're learning that these genetic changes cause many of the differences in the organs of these kids, including the way that the heart forms, but also the way their brain develops. Some of these kids will have developmental delays or behavioral problems, and we are understanding that these are linked to their genetic changes. After birth, there are other concerns that impact the brain function and development. We know that babies born prematurely are at higher risk as their brains are already impaired, and now they have not had enough time to mature to their potential. After birth, when babies start to breathe air and use their lungs, the blood flow patterns change dramatically. Where there was no flow to the lungs in the womb, now all the blood must flow to the lungs to get enough oxygen for the organs to function. These changes in blood flow sometimes result in too little flow to either the lungs or the other organs, lower blood pressure or lower oxygen levels, both of which can add risk for additional injury to the baby's brain. Some babies lose the heart's ability to pump blood flow adequately, and they may need CPR or ECMO for a short period of time, either before or after surgery. These both have the potential to injure the brain with risk of stroke. Some of the procedures that we do to babies with heart disease, like opening a hole in the top chambers with a balloon or ballooning a valve in the first weeks of life, can also cause injury to their brain. We know that about 40% of infants with CHD who need heart surgery in the first month of life already have brain injuries, and we can see those injuries on CT or MRI even before surgery, meaning they were born with those injuries. Another one-third may develop new injuries after surgery. The most common injury is damage to the white matter of the brain, followed by strokes or bleeds. These images show those injuries in the brain as bright spots in these two babies with hypoplastic left heart syndrome, here, here, and here, and in this baby with transposition of the great arteries, here. For many years, we've tried very hard to understand how we can protect the brain during surgery to prevent injuries like these. We have changed cardiopulmonary bypass techniques, but we know they cause only a small fraction of the injuries to the brains of these babies. The intensive care unit is another place that may contribute to brain injury. As many of you will recall, the ICU environment is filled with bright lights, loud noise, cool temperature, frequent handling of babies, and frequent painful stimuli. Many babies have postoperative seizures. Some may need ECMO for part of their ICU stay. Some have bleeding or clotting problems. Some may have heart rhythm problems. We know that babies needing long stays in the ICU have a higher risk of problems with neurodevelopment later in life, regardless of what surgery they had. Overall, though, what happens during surgery and after surgery only explains a small portion of the brain injuries that occur, less than 5% of neurodevelopmental problems. whereas genetic changes and cardiac disease, along with abnormal blood flow in the fetus, account for up to 25%. Childhood and adolescent are also times of vulnerability. Some kids require additional heart surgeries or cardiac catheterization procedures. For children with heart conditions that will need a Fontan procedure, we keep them quite blue for the first years of their life, likely contributing to neurological injury over time. These multiple procedures and the scars they leave on the outside can profoundly impact self-esteem and the feeling of being different from their peers. Many heart conditions impact exercise tolerance and the ability to keep up with peers in sport. Neurodevelopment changes may limit the ability of some adolescents to pursue higher education. Finally, transition from pediatric to adult care happens at 18 years of age in Alberta, at a time when there are many changes in a young person's life. Young adults with impaired ability to plan and make decisions, problems with memory and attention, contribute to the 50% of kids with congenital heart disease that fail to make the jump to adult care and are lost to follow-up. We are seeing higher rates of dementia in our adults with congenital heart disease, sometimes under 65 years of age. We are looking at why this is and wonder if their brains are more vulnerable because of all the injuries they have had throughout their lifetimes. We need to understand this more in coming years and find ways to improve these outcomes. So, what have we learned? We've learned that our kids' brains are different, and those differences start when they are in the second or third trimester of pregnancy. Some of those changes are genetic, even if we don't know for sure what the genes are that cause the changes. Some of these changes are due to differences in the way that blood gets to the developing brain, resulting in less oxygen and nutrients, smaller brains with less folding, and injuries in the form of tiny bleeds. We have learned that the therapies we do to kids with serious heart disease, like surgery and catheterization, anesthesia, CPR, and ECMO, all add additional insults to vulnerable brains. We know that kids with serious heart disease have a specific pattern of developmental problems, and while most of these are mild, they greatly impact all aspects of the child's life, and for some adults result in challenges in taking their rightful place in our communities. And with that, I will hand it over to my amazing colleague, Dr. Vasserman, but not before reminding you that congenital heart disease awareness is coming soon, February 7th to 14th. Thank you.
Now that Dr. Myers has provided an overview of heart disease and how it affects aspects of brain development, Dr. Marsha Vasserman is going to speak about the impact of those developmental changes on function and development in childhood.
So we talked a little bit about the impact on the brain, and I'm going to talk a bit more about what does that look like, and what are these brain pieces that we're talking about, and how do they affect development. And as Dr. Myers had already talked about, obviously the brain and the heart do develop in parallel. So everything that affects heart development can have the potential to affect brain development as well. One of the interesting pieces that this is true about the adult brain, that, even though it makes up about 2% of our body weight, it uses 20% of the oxygen that we have. For babies in utero, it's 50%, right? So that's why it's so susceptible to some of those decreases in oxygen supply. And this starts very early in development. And by the third trimester, that last trimester, so much growth is happening in our brains. That's when all of that myelin forms and a lot of cells are moving and developing, and those oxygen changes can really affect all of those pieces. The other piece that we have become very aware of is that the brains of kids with heart disease tend to be more immature, right? And so because they're more immature, they're much more susceptible to any other sort of injury. They're actually very similar to the brains of kids who are born very prematurely, right? There's some biochemical changes as well. And as Dr. Myers had mentioned, there's high rates of white matter injury. And we'll talk about what is white matter, why is that important, and what does white matter injury actually look like in function. As mentioned previously, the rate of injury is pretty high. About half of newborns are classified at birth as neurologically abnormal. Well, what's that, right? And that could really mean a lot of different things. It could mean that you have low tone, which doesn't necessarily mean you're going to have significant cognitive difficulties as you get older, but it just tells us that those brains are already a little different and are having more difficulty. This is okay. So one of the, it means you can have low tone. It means that you might have some motor asymmetry, right? So you're not using one side as much, which can indicate stroke. EEG findings are one of those things that we know are very sensitive, but not specific, because pretty much everything can affect what your electrical activity of the brain looks like, but it doesn't necessarily say it's something specific. And there's differences between like abnormalities on EEG versus clinical seizures. So we know that a lot of babies with congenital heart disease will have abnormal EEGs, even though they don't have overt seizures, right? They don't have those seizures, but their EEG is abnormal. And interestingly, those abnormal EEGs after surgery tend to be one of the better predictors of later neurodevelopmental struggles, right? So sensitive, but not specific. So what's white matter? Why is this important? So if we look at, I'm sure everyone's seen pictures of the brain, and some of it looks dark and some of it looks a little lighter. So there's gray matter, which is basically all the neuronal cells, all the cell bodies. And then there's white matter. And those are the long axons that basically send messages from one cell to another. And if you think about wiring, like electrical wiring, you know how there's like that, not plastic, but whatever, like rubbery coating to protect the wire. That's kind of what white matter is. And it allows messages to travel from one part of the brain to another part of the brain extremely quickly, right? So you know how like you don't think about moving your hand and it just moves? That's what white matter is doing. And so what is it involved in? Pretty much everything. It's involved in everything, right? And there's lots of pathways, like highways in our brains from one part to another that are made of all white matter, and it allows those messages to travel really fast. And so if you have any changes in that white matter, it means you might be a little slower in certain tasks and thinking and processing information. It's implicated in motor skills, how quickly you can move, how well you can move, how well you can coordinate movements, visual perception, right? Can you look at that visual information and piece it together, figure out how things go together? In real life, navigate a map, right? Processing speed, how quickly can you work? How quickly can you process information? Attention and executive functioning. And I'll be talking a little bit more. I see some heads nodding, right? Attention and executive functioning are very highly dependent on white matter and are very widely distributed through the brain, right? So I'll talk a bit more about those. We're potentially impacting kids with heart disease, right? They have more mature brains, they have a higher risk of additional injury, there's continued growth delays because of potential changes in oxygenation. There's changes in how neuronal cells migrate and where they go during brain development, and reduced overall growth. So lots of things that can affect how kids with heart disease, how their brains can develop. And so how does this translate into function, right? So one of the things that we do see is when kids are young, they might be later to speak, they might have delays in language, they might have delays in gross motor development, so things like crawling and walking, and fine motor development. So beads, zippers, buttons, right? Handwriting. Now, early on, right, like if you walk at 8 months, that's normal. If you walk at 17 months, that's normal. That's a pretty wide range. So sometimes spotting those difficulties in early age is much harder because what's considered normal is much wider. And unfortunately, a lot of physicians and pediatricians have this tendency of like, oh, just wait. With kids with heart disease, don't wait. If you have concerns, bring them up, right? If a child has any sort of underlying medical issue that puts them at greater risk for developmental struggles, we don't want to wait. We want to identify things earlier. That's one of the reasons we're doing this, right? To kind of give kids more information, right? And then as they enter school age, higher rates of learning disabilities. So specific learning disabilities in reading and writing and math. More likely to have attention difficulties and problems with executive functioning. And I'll talk a little bit more about what that executive functioning piece is. And they may have more mood and anxiety symptoms, right? So depression, just worrying, social and peer difficulties. We know that kids at with heart disease have a higher rate of social cognition struggles, right? So taking other people's perspectives, being able to kind of put themselves into other people's shoes and be flexible with peers. So that's an area of struggle. And actually, let me talk a little bit more about the attention and anxiety piece now. So attention is, I think everyone knows what attention is, but attention is actually something, there's lots of different types of attention. There's, you're listening to me right now, I'm going to tell you a phone number, and when we hang up, you call me back. So you have to be able to hold a pretty discrete piece of information, a phone number, not a whole lot, for 5-10 seconds, right, until you dial it back. That's called working memory, very basic attention. Then there's divided attention, right? Being able to kind of split your attention between two different things, like managing your kiddo and listening to me, right? So those, like being able to multitask, split your resources between two different things. And then there's sustained attention and persistence. So being able to listen to, sit in a classroom, lecture, listen for a prolonged period of time, resist distractions, and kind of be able to really persist on something that's effortful, challenging, not overly motivating. All of those are impacted in kids with heart disease, right? And executive functioning. So that's something that I think the term gets tossed around a lot. Within our field, we don't have one definition of what executive functioning is, but everyone kind of agrees that it encompasses multiple different skills, including inhibition, right? Being able to kind of resist your impulses and wait, being able to plan, organize, and orient your behavior in order to reach some sort of long-term goal. So kids with executive functioning difficulties are notorious for having a hard time managing time, being, really struggling to keep track of their stuff. Yeah, I did my homework, but I forgot to hand it in. No, I didn't do my homework because I didn't remember that it was due until just now, right? So all of those planning and organizing skills are a struggle. You've bought 15 water bottles and 20 toques over the course of a year, right? So those are the types of skills we're talking about. And the thing about attention and executive functioning skills, again, if you go and have a child evaluated or you talk to someone about concerns at the age of 5, 6, they might not see those difficulties because the tasks we're asking 5, 6-year-olds to do at home don't require a whole lot of attention and executive functioning skills. That's why a lot of times we don't really see or we don't hear about these struggles until kids enter school and all of a sudden teachers are saying, hey, so-and-so is really having a hard time following directions and staying in circle time and being able, their desk is a mess, right? So that's why one of the things that we really want to make sure we're doing is not just looking at kids early in development, but really following them over time, because those skills are starting to develop in preschool and continue to develop well into young adulthood. And what they look like and what those difficulties look like changes over time, right? What's being done about this? So, Dr. Myers and I kind of talked a little bit about the fact that we are now, or Dr. Myers did, we're really focusing more on the neurodevelopmental piece because there's such better outcomes. We're seeing a lot of these difficulties more frequently. And because of that, lots of organizations have developed a set of guidelines saying we need to be screening and following kids with heart disease regularly throughout childhood. And the guidelines state that surveillance should occur for all kids. And surveillance means like just checking in with parents, how are things going? Do you have any concerns? Even the low risk kids, surveillance should be happening pretty regularly because risk can change over time, right? As we talked about all the different things that can impact its development. And then conducting screenings at certain ages, right? And if any of those are positive, then doing more of an assessment, more comprehensive evaluation are recommended at those points. What are we doing at Alberta Children's Hospital? So one of the things we're doing, one is these workshops, right? So our goal is really to spread the word to families, parents, clinicians, teachers on the neurodevelopmental risk, what that looks like, and how to support kids. We have started a cardiac neurodevelopmental screening program at Alberta Children's Hospital where we're screening kids with moderate to severe heart disease pretty regularly at their follow-ups with parent questionnaires. So it isn't, so it's really just kind of parent report on what are you guys seeing at home? Do you have any concerns across all of these different areas? And we ask questions about learning, attention, executive functioning, mood, peer relationships. And then if there's concerns in any of those, we decide what supports might be necessary, an evaluation or a referral. We are working on starting a social skills intervention group for teens with congenital heart disease and are hoping to bring some behavioral intervention to early childhood, right, to parents of younger kids with heart disease that might be having some behavioral difficulties, adjustment difficulties, stuff like that. And just increasing collaborations between all of these different folks and working with the community. So what should you do if you have concerns about your specific health? One thing that I always recommend is talking to your cardiologist and the cardiac team, because as Dr. Myers had mentioned, a lot of hospitals have started cardiac neurodevelopmental surveillance and follow-up programs. And so depending on where you're being treated and what hospital, they may have something in some ways of supporting and directing or a kid with concerns to specific resources. So they may refer you to a pediatrician if there's concerns about attention, or they might refer you to community resource for mental health if there's mood, anxiety, or potentially a broader, more comprehensive assessment if there's learning concerns. The other part is contacting your child's school. So if your child is school age, there's some difficulties with whatever it is, attention, development, learning, talk to your school. Some kids will have IPPs, some kids will not, right? Schools are not knowledgeable about this, and that is definitely something that I want to change, that we're hoping to change over time, is to educate schools about that heart-brain connection and how it could affect learning and development over the course of school age. If your kiddo does have an IPP, read it, because sometimes those goals are very generic. If you think they're generic, write out some goals that you think need to be addressed, right? So IPPs need to be specific, they need to be measurable, goals need to be measurable, and they need to be able to have a metric of how do you meet this goal. Getting better at reading is not a goal, right? Reading with 80% fluency at a grade 3 passage is a goal, right? And so that specificity varies by school, it varies by district. And sometimes we need to be the advocates, parents need to be the advocates on how to change that. You can also request that schools conduct an evaluation. Here in Calgary, that's really difficult to achieve. In other places, it might be a little different. Schools generally will have only a couple assessments per year that they have resources for. But there are ways to advocate within the school setting. If you're involved with a psychologist or your cardiology team has an educational liaison, which some do, those might be good people to involve as well in those conversations with school. And some parent resources. So Heartbeat is a Calgary grassroots organization that has been providing families with information, resources, financial assistance, emotional support since 1987. They are sponsoring our talks and are here with us today. The Children's Heart Society and the Western Canadian Children's Heart Network are wonderful organizations that provide a wide range of resources and support throughout Western Canada. So those are some to get involved with. There's little Instagram QR codes.